Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Periods, I'm Tired of Them. What are my options for treatment? And it is presented by Anna Kalbfell, who is an obstetrician-gynecologist practicing at our location on the campus of Schoolcraft College, and also David Eisenstein, who is an obstetrician-gynecologist practicing at our Bloomfield Hills location. And I believe, Anna, you'll be kicking it off.
Thank you, Allison. Thanks. This is Dr. Anna Kalbfell. Thank you for that wonderful introduction. So it's my pleasure to be here with all of you tonight. I hope to provide some hope and insight for those who are tired of their periods. I first wanted to start off with a few definitions of words you may hear tonight. So first of all, the endometrium is the lining on the inside of the uterus that's lost with your period. So this is why sometimes it looks like you pass tissue or weird looking clots with your period. So if you hear us talk about endometrium, that's what that is. You also may hear us say menses instead of period. That's just a fancy medical term for period. That's all. And so I kind of use them interchangeably. So you may hear me say both of those words. And lastly, when we refer to a menstrual cycle, that means the time between the start of one period to the start of the next, or roughly 1 month. So some people confuse the length of their actual period with this, and they're in fact a little bit different, the cycle versus the actual period length. Let's see. There we go. So first, let's talk a little bit about what makes up a period. So an average period lasts about 5 days and occurs every 21 to 35 days. The average flow is less than 80 milliliters, which is roughly 1/3 cup. And that's over the course of the entire period. So this equates to about 4 to 5 pads or tampons per day on those heaviest days, depending on how many or how saturated they are when you end up changing them. If your periods are outside these parameters, the diagnosis of abnormal uterine bleeding, or AUB, is made. In some studies, 1/3 of GYN visits are for AUB. So if this is you, you're not alone. But with that said, your periods can still fall within these parameters and still be bothersome. And so management can still be discussed. That's not a problem. If you want to change the way your periods are, call your GYN to discuss this further. We'll talk tonight about why you should. I do want to point out too that many women suffer from painful periods or dysmenorrhea, not just heavy periods. I won't be specifically addressing that symptom today. However, it is related, so there is some overlap in the treatment options. As a general GYN, a majority of my patients come to me complaining of irregular or heavy periods. So that's why I decided to focus on that tonight. So here is a long list of possible causes of heavy or irregular periods. I am not going to go through this tonight and go through each one of them, but I wanted to provide this list just as a sample of some of the causes that I'm looking for when I see a patient in the office. I ask a lot of questions that first visit to find clues about what might be going on so that I can narrow down this list and really tailor the patient's care for them specifically. This is why making an appointment to talk about your periods is important, so we can kind of dive down and figure out what exactly is going on. Okay. So what to expect during your GYN visit to discuss your periods. So as I mentioned with the last slide, there are many possible causes. So I use a history and physical to guide the next steps of the visit. The 3 main things I use to help make a decision are the exam, labs, and imaging. And then sometimes we need a biopsy. So depending on the woman's age, a pelvic exam is performed to identify any structural causes like fibroids or ovarian cysts or polyps. Under 21, which is the age when Pap smears actually start, a pelvic exam is offered, but it's not always performed. So over 21, I recommend an exam with both a speculum and a manual exam to feel the internal structures. During this exam, swabs for infection can also be collected. If someone's concerned about the exam portion, a discussion can be had to determine if questions can be answered without an exam. So I don't want this to be the reason that you don't come in for evaluation. The next step is typically drawing blood labs to check several labs. The list of labs depends kind of on the information that's gathered during the history, but typically involves a blood count or a CBC, any appropriate hormone testing, and then any labs that may explain any of the other symptoms that you have. So lastly, an ultrasound can provide additional information that cannot be seen on the exam. This is typically a vaginal ultrasound, as the uterus and ovaries can hide deep in the pelvis, and this is the best way to visualize them. So depending on the results, a more specialized ultrasound may be warranted to look specifically at the uterine cavity or the inside of the uterus. For some patients, especially if over the age of 45, a biopsy of the inside of the uterus or the endometrium may be warranted. This is mostly to look for cancer or precancer. This can be done at the initial visit or in a return visit after taking certain medications to make it easier. Again, the usefulness of this is discussed during your visit and is not always needed. So at the end of the visit, I then discuss a few treatment options that can be started that day, but otherwise we wait until the results come in, like for the labs and the ultrasound, and then go from there to tailor the care. So now let's dive into some of the possible treatment options. I know that's why everybody's here, so let's jump right in. So the treatment options for AUB, or abnormal uterine bleeding, include both surgery and non-surgical options. I'm going to discuss only the non-surgical options, while Dr. Eisenstein will cover the surgery options. I will also further break it down into hormonal versus non-hormonal options, as each has its own set of like risks and benefits. So let's first start with some of the non-hormonal options. We have two medication options that exist for women with heavy or long periods. So the first is using NSAIDs like ibuprofen or Motrin or Advil, but you have to start it before the period starts. Many women tell me that they already take NSAIDs during their periods, mostly for treatment of cramps. However, they do not start this before the bleeding starts, and this is key. The reason this is important is because these medications decrease prostaglandins, which is a form of inflammation. When inflammation builds to high levels, it increases blood flow to the area and therefore causes heavier bleeding from the uterus. By starting it before the period, you prevent the prostaglandins from increasing too high and therefore decrease the inflammation in your body and can slow the bleeding from your period. Now, the challenge of this is being able to start it before the bleeding starts, because once the bleeding starts, that inflammation has already reached a high level. If periods are unpredictable, this can be near impossible. So the advantage to this method is that ibuprofen is fairly cheap and can be purchased over the counter, and most of us women have one of these forms of NSAIDs in our drug drawer already. It has minimal risks associated with it. However, one downside is that it only works for about half of the women that try it. The next non-hormonal treatment option is something called tranexamic acid. So it's also known as TXA or Lysteta, and it's a medication that slows the body's ability to break down clots. So this is beneficial because as the endometrial tissue is sloughed off during the period, the end of the blood vessels that go to that endometrium are left open, and they need a clot to form to essentially slow and then stop that bleeding. The body naturally breaks down any clots that we form in a certain amount of time. By forming a stronger clot, it doesn't break down as quickly, and the overall bleeding then slows down. I know passing clots during your menses can be concerning, but in this case, the clots are actually beneficial just because of where they're located. It doesn't necessarily increase the amount of clots that you see coming out. So one important thing to note, though, is that this medication does not cause you to form clots in your body. It only works to strengthen the clots that your body has already formed, aka in the uterus during your period. So this medication needs to be taken 3 times a day, which sounds like a lot, but it's not started until the bleeding actually starts, and it's only taken for 5 days total. The rest of the month, no treatment is needed. So this medication can also be taken with ibuprofen if you're also having cramps too. So while one downside to this medication is that you can only use it once a month. So if you have more than one period each month, or you have one that comes a little early, you can't use it for the second one that month. So sometimes it doesn't slow down all of your periods. So I think it's also important to note in this section too, that there's two other ways to adjust your periods that do not involve taking a pill. So these two other non-hormonal treatment options I discuss with patients are weight loss and reducing inflammation. So we know that excessive weight produces estrogen. So estrogen is like a fertilizer to the endometrium. It encourages the endometrium to grow during the menstrual cycle. So by reducing the overall amount of estrogen in the body, aka losing weight, the endometrium doesn't grow as much and there's less to slough off each month. So therefore the periods become lighter. Even losing just 10% of your body weight can cause noticeable changes. So you don't have to focus on losing 50, 100 pounds, nothing too crazy. Just a small weight loss can cause some changes. So also reducing the amount of inflammation in the body can also reduce the amount of bleeding we have. So remember that the NSAIDs we discussed earlier focus on decreasing inflammation, right? This reduces the flow of your period. So you can have similar results with an anti-inflammatory lifestyle. This includes increasing foods that decrease inflammation, avoiding foods that increase inflammation, getting enough sleep, exercising regularly, reducing your stress, those kinds of things. So although the non-hormonal options can reduce the flow of your period, like how heavy they actually are, one thing to consider is that these options will not change the frequency or how often the periods occur. The only way to do that is with hormones. So we'll talk about those next. Let's see. So hormone treatments are used to regulate the menstrual cycle, like I mentioned. Throughout this cycle, we have a normal up and down of several hormones, as you can see from this diagram off to the side. Sorry, it's kind of blurry. It's a combination of this up and down that determines when the period will occur. So hormonal treatments focus on regulating this up and down and then regulate when the cycle occurs. So the most common form of hormonal regulation we have is the various forms of birth control. So these medications have been well studied, so the effects, the risks, and the benefits of each are well known. And there's also two basic categories for hormonal medications: those that contain both estrogen and progesterone, and those that contain only a progesterone. Although they have similar effects, we'll dive into these separately. So let's start with the options that have both estrogen and progesterone. The advantage of these is that they mimic the normal cycle, but with less hormones. So the endometrium doesn't grow as much. This causes periods to be shorter and usually lighter than usual, along with becoming a little bit more predictable too. The most common form of hormonal regulation is the birth control pill. It has a low dose of both estrogen and progesterone, and it's taken every single day at about the same time. So the advantages of the pill are that there's several different formulations. So the hormones can be adjusted based on your symptoms. And then after about 2 to 3 months of use, your body kind of stays on the same cycle. And so the periods become more predictable, where you can actually look at the pack and almost know exactly when your period's going to start, usually within like a day or two. The downside to the pill is that it has to be taken every day at about the same time. So that can be a little bit tricky with a busy schedule. It can also cause a little bit of nausea too. So the next combined treatment option is the transdermal patch. This is a patch that's placed on the skin and worn for 1 week. Like each patch is worn for 1 week, and you do that for 3 weeks in a row. The 4th week, no patch is worn and the periods happen. This is repeated each month to produce that regular cycle. The advantage of this is that it's once a week, so you just pick your favorite day. It's a little easier to remember. The disadvantages of the patch are that it has the highest risk of blood clots forming in the veins than the rest of the hormonal options. It's still much less than getting pregnant, but it is the highest out of all of these options that we're talking about. And it obviously sits on your skin, so it can cause a skin reaction. Lastly, there's 2 different vaginal rings. So the ring is placed in the vagina, kind of similar to a tampon. The NuvaRing can remain in there for 3 weeks. At the end of the 3 weeks, it's removed, and that's when the period starts. With NuvaRing, you have to start up a new one with the next month. The other brand you can use for 13 months in a row, so it's essentially reusable. The advantage of this one is that you only have to remember it twice a month, once to put it in and once to take it out. The disadvantages are some women notice an increase in vaginal discharge or difficulty inserting or removing it. So since all of these options contain both estrogen and progesterone, they do carry the risk of blood clots in the veins, weight gain, headaches, breast cancer. These risks are discussed at your visit to determine if this medication is a safe option for you. Let's see. So the next class of hormonal treatments are those that contain only progesterone. So if you're looking to get rid of your periods altogether, this is the slide for you. So the first option in this category is another pill. However, this one has lower hormones than the combined pill we previously talked about. It has only progesterone, no estrogen. The advantage to this pill is that since it has lower dose hormones, it has less side effects and less risks. It can also be used continuously so as not to have a period at all. Now, I will say the caveat to that is that sometimes the hormones are so low that the uterus does not like that, and it can cause some spotting in between periods. If this is the case, we recommend inducing a period every few months, every 3 months, every 6 months, whatever your uterus needs. The next option is the Depo-Provera injection. So this injection is given every 3 months. The main advantage to this medication is that most women do not have a period while taking it. Now, with that said, it can also cause some irregular bleeding the first 3 months of use as your body's getting used to that dose of progesterone. It can also cause weight gain, and it can make depression worse. But this doesn't occur for everyone, and is something to discuss during your appointment. Also, after 5 years of use, a conversation about bone health should be had, as it can weaken the bones if used longer than that. So the third option in this category is progesterone-only IUD. So the most common one that you hear about is Mirena. Mirena is a small T-shaped piece of plastic that is placed in the uterus during a procedure in the office. It releases progesterone locally in the uterus, causing the endometrial lining to stay thin and then not grow. Since it's placed in the area where it needs to work, aka the uterus, it has the lowest dose of hormones. With that said, you can still have ovarian cysts with it because you can still ovulate. There is also a risk that it can be pushed out of the uterus or go through the muscle of the uterus. The IUD has the best rate of amenorrhea, aka it has the best chance of those periods going completely away out of all of the options discussed here. Perfect. So that's all I have for the non-surgical options. Here is my office information. And with that, I'm going to turn things over to Dr. Einstein.
Good evening, everyone. Thank you to Dr. Kalbfell for that very detailed interrogation of the issue of abnormal bleeding. When I was asked to give the focus of what my talk would be, I gave this answer about treatment options at 40 and beyond because it's a time of life that really interests me in terms of the type of choices that women face and the type of issues they bring into me when we discuss these in consultation. Now, this doesn't mean that this talk is exclusive of anybody younger, but what I had in mind was this interesting problem where women, perhaps in the later years of reproductive years, let's say from 35 on, will sometimes encounter from us doctors this question of, why don't you just have a hysterectomy? it's the kind of sentiment that patients have brought in to me when they are interested in getting opinions about this situation quite often. And that framing of the question, Doc, do I have to have a hysterectomy, or do I need a hysterectomy, is a fascinating framing of the question, because that question of have to or do I need, I'm very interested to think about, does it mean that that's the only option this patient has been offered, or are they under the impression that that medicine in general only narrows their options down to this? Or are they saying, I really don't want a hysterectomy, so help me find another path forward? So that's why I framed this talk in these terms. Just as a point of introduction, Trinity IHA is developing what we call Advanced Gynecologic Surgery Service that myself and colleagues across the system are developing. And what we want to have to offer patients is what I call high value, high volume surgical services. What does this mean? It means that we want high value for patients, meaning the right choice in the right situation for the right patient, giving them a treatment, no matter the particular technology or modality, whether a robot or not a robot, or a conventional small incision surgery or other approaches, but that have the best impact for the patient with the least burden on them in terms of time spent in a facility and recovery at home. And high volume, because we know that the surgeons who are regularly doing these procedures have the best quality in terms of low complication rates, both during surgery and bouncing back to the hospital with complications such as infection. And we're focusing on the more complex type of gynecologic cases, heavy bleeding and menstrual bleeding, tumors of the uterus, fibroids, pelvic pain, and endometriosis. You notice that cancer care is not included in this list, because really we have a subspecialist in dealing with cancer. There is actually a fairly extensive amount of literature, articles in our medical journals that tell us, doctors, what our patients are saying about what they encounter sometimes when they bring issues into the doctor. Oh, excuse me, I didn't mean to, let me go backward. And there is a concept that to set the table for the discussion of the specific treatments I want to touch upon tonight, of what we call patient-focused care. And the theme is nothing about me without me. In other words, we physicians are going to best serve you as patients when we let you lead us, so that we can best ascertain, as we work up the problem, what are the kind of treatments that will work best for you. And these are the kind of things, when you survey patients, they will tell you the experience. This particular list of quotations was specifically asking patients about their fibroid care. And that you can see from the spectrum of comments that patients offer, and this is just a small sampling from some of the articles you can find, that either the problems weren't legitimated, or they felt that the problems weren't worked up sufficiently, and their physicians were very quick to just do empiric things without a workup, or that they suggested or contoured the care for patients to things that were not congruent with those patients' personal goals. This is particularly true about fertility. Hence, the issue of being, let's say, over 35, over 40, and having an issue, and maybe you're not planning to be pregnant or ever again pregnant, but the idea of simply saying that you could never get pregnant again was something that is a profound dissatisfier for a lot of women to encounter in talking about their options. So do I have to have a hysterectomy? What are the common conditions? And again, I'm talking about not cancer. So this is exclusive of cancer issues. And on that note, I would just mention tangentially it is our responsibility, every gynecologist, healthcare provider for women seeing you, that we ensure that that's something we don't miss. So part of the workup is making sure that through tests and imaging like ultrasound or biopsies, that's one of the things we have to make sure is not going on when somebody comes to us with a pain issue, a menstrual bleeding issue, and similarly. But aside from that, what are the real common reasons that lead women to have the 450,000 or so hysterectomies that we have in this country every year? Well, it's heavy menstrual bleeding, here designated as AUB in this list, uterine fibroids, and I think most people know what those are, and I get a little more into detail about that in a few slides. Pelvic pain, and the most common reason for pelvic pain, number one reason is endometriosis, and prolapse. And prolapse, of course, is when the supporting uterus and between the bladder and the vagina, or between the most common reason for this is having had childbirth. So the uterine sparing option, meaning if I'm approaching heavy menstrual bleeding, pelvic pain or pressure, the development of uterine fibroids, and I'm not ready to spring for a hysterectomy, how do I take that journey? And by the way, I would say that I always like to say that there are three kinds of people I tend to talk to in the clinic. Patient one is somebody who's already determined for themselves that I just want to finish with this. Please give me a hysterectomy. That type of person, when I start sitting and investigating these other options, are very quick to sort of short circuit the conversation and say to me, look, I appreciate you wanting to talk about it, but I'm done. Let's just sort of talk about how to do a hysterectomy. There are people who come with that pure mindset, and they've been referred to me because they've crossed that Rubicon of decision making. I want a hysterectomy. There's another side to this where patients have come in and they are absolutely committed to maintaining intactness of their uterus. And there's the patient in the middle. And I think that probably defines most of the patients I see who are trying to navigate their problems and understand where these treatment options fall and where hysterectomy might fall. They might not be ruling that out, but they don't want to be strong-armed by any means by my counseling in that direction. So patient selection becomes the real issue. And patient selection is a concept that means, what do we understand about the patient herself, the issues she's having, and what we ascertain are the reasons the issues are occurring, in order to give them the type of treatments that, number one, will work, number two, will not be too much of an intrusion into their lives or to the least intrusion possible, and number three, what's going to be the safest for them in the long term. And of course, what's written here on the slide is everything that Dr. Kalbfell went through already. First of all, is the story. What's the narrative? And what is the context for that individual patient's narrative in her personal story? Physical exam is important. And then a basic sequence of diagnostic testing. And again, I don't want to go over everything we already heard, but we want to know, are you anemic? Is your iron low? Are there problems with your clotting system? Are there other hormonal things, prominently things like thyroid conditions that we need to know about? And then what does the anatomy tell us? And the two most effective modalities of imaging that we use in gynecology are ultrasound and MRI. CAT scans for primary workup is unnecessary ionizing radiation. It doesn't really have a role in this mode of workup for patients. And then we have to look at, after we understand all of that in the context of what your patient goals are, what are the treatments that are safe, effective, long lasting for you, and are they matching your personal goals? And matching your personal goals means fertility, what's your relationship to fertility, what's your relationship to the idea of uterus being intact, what's the relationship to your goals as a sexual person. All of those things should be thought about, talked about, to the degree that you individually as a patient want to discuss them. So here is a visual graphic of the spectrum of treatments that, going from left to right, you see the idea of watchful waiting. Since most of what we're talking about, we assume we've ruled out cancer, depending on any individual patient's state of mind and her sense of urgency, we have the luxury of taking some consideration of what will be best for you. And as we move across the spectrum going from left to right, we see the arc going from medical treatment to certain procedures and then surgeries to remove parts of the anatomy. And how I look is kind of what I call the bang for your buck vector, meaning you are going to be seeing a little more intrusiveness, maybe a little more side effects. But as you move further to the right, you also have probably higher effectiveness, longer lasting therapy. So ablation has become a very common option for heavy menstrual bleeding, and it's become basically synonymous with endometrial ablation. But there's another ablation procedure, and I wanted to mention the two to distinguish them. So ablation is a generic word, and it essentially means the ability to injure or destroy tissue with energy. And that energy usually means heat. And the most common way to do that is through current that comes from a generator we plug into the wall. And so that's a generic term. That's what ablation does. When we apply it to the lining of the uterus, we call it, the generic term for it is global endometrial ablation. So this is a very, very common procedure that gynecologists offer patients. Pardon me for one moment. My very loud children over there. We offer it for patients with bothersome heavy menstrual bleeding. And the appropriate patients for this have essentially normal anatomy, no cancer. Painful periods may be a reason to avoid this procedure, and it's not a specific treatment for fibroids. There are different technologies that we use to achieve the effect on the uterus. However, the most common one is electrical current energy. And just like I was saying earlier, the patient selection is very important for the success of this procedure, because fertility concerns may mean this is not a good choice for you. And there are various conditions that patients may have where there can be complications to this procedure. Up to 5% may have what's called a post-ablation syndrome due to pain and scarring in the uterus. So it's very important to be very careful, particularly considering how popular it is, to make sure you are the right candidate for it. So the other ablation that is coming up now is for uterine fibroids. And I'm going to introduce it by mentioning fibroids per se. So the challenge of fibroid tumors is that these are very common. Most people know about them and know what they are. They're common, and as I put here, generally benign tumors of the uterine muscle that, depending on the demographic of patients you're talking about, 50 to 80% of women might have them by the age of 50. Sometimes they don't cause any symptoms and people live with them, but sometimes they can cause very major symptoms. And there are many treatment options here. although it is a very common indication for hysterectomy. I'm putting up the same slide that we saw earlier about the spectrum of care. I've only added one extra thing here under medications. There is now an oral medication, and there are a couple of them out on the market, which are very effective for heavy menstrual periods associated with uterine fibroids. It has to, again, be the right patient. There are certain limitations on how long you can use the therapy. However, they do work. For heavy menstrual bleeding, these medications work very, very well. But the bigger picture is that this was a slide I showed as a general slide about treatments for the spectrum of conditions we're talking about tonight. But for fibroids, it's pretty much the same thing. And what you see over by what I call the intact procedures are procedures that affect the uterus without taking anything out. So you have fibroid ablation, you have uterine fibroid embolization, which is a procedure our radiology colleagues can do for us. I put endometrial ablation up there as well. And then there are removal procedures, meaning we can take fibroids out, or we could do hysterectomy. So what is ablation? I already mentioned as a general proposition what the word ablation means. And then when we apply it to treating heavy periods by burning the inside of the uterus out. But it can also be applied to treating fibroids where they exist in the uterus. And this is called radiofrequency ablation of fibroids. So the indication for this is pain or pressure or heavy menstrual bleeding. It can be performed either by laparoscopy, although there's a newer device that can be performed through the cervix. And the effect of doing this to uterine fibroids is that it will reduce the size of the fibroids in the uterus by an average of 44% by volume, and it works about 80% of the time for the symptoms. And then we have found so far that we have to retreat fibroids in about 11% of patients. And that's something we have ongoing study. And I'm the lead researcher in a 5-year study. We're about 3 years out now as we compared taking fibroids out, that's myomectomy, versus treating them in place with ablation. And that's ongoing, and we're publishing data on that every year as we go forward. So what's the difference between removing fibroids or ablating them? Well, a myomectomy is basically appropriate at all ages, and your surgical approach depends on how many and how large the fibroids are. It is the most traditional approach when fibroids seem to be in the way of getting pregnant, and patients do have to know that the one issue with fibroids is that they can regrow or new ones can form, and the research on that says that that's about a 20% chance over 10 years. Versus fibroid ablation, which is somewhat of a more what I'd call a niche procedure. There are some limits on the size of fibroids and the number that you can reasonably treat effectively. When it comes to fertility, the desire to get pregnant, it's still unclear the role for ablating the fibroids if you want to get pregnant. And the FDA has taken a sort of wait and see posture on that. But there is a lot of data, including some of my own patients in those papers, that show that normal pregnancy can occur and be successful. So this is an ongoing conversation that if this is right for you, but you want to have a pregnancy in the future, you talk about it very carefully with your physician. The one great thing about it is it's definitely an outpatient procedure, and patients are back to activity very, very quickly. And so far, the results on impact of pain and heavy menstrual bleeding have been quite good across the board. Now, my last slide is about that hysterectomy and that concept of nothing about me without me. There are a lot of issues to talk about with your physician if you decide to have a hysterectomy. And I really encourage you to be a strong advocate in that conversation of what's important to you. And I'm just throwing this one paper as an example of the kind of thing that we physicians really need to pay attention to you guys as patients. there are different ways you can take a uterus out. And when patients are asked, what do you prefer your tummy look like after a hysterectomy? And they were shown these pictures, about 64% ranked choice C, which is called a mini incision or laparotomy. 26% ranked D, which is a traditional laparoscopy. And nobody in this study ranked choice E or choice number 1. Choice E is how robotic surgery looks. And choice number 1 is a traditional fan and steel incision, which is the larger C-section type incision. I just throw this out there because I think it's interesting that what doctors think is the best approach for you may not exactly match what our patients are actually desiring or thinking. So be your best advocate, talk through these things. What are the different options for me if I chose to have this kind of surgery? What am I a good patient selection for? And let me be part of that conversation of the route and choice to hysterectomy. This is just a small part of that conversation, but it's a reminder to all of us physicians that our patients have their own points of view on what's best for them. So with that, I'm sorry for the interruption in my system, losing connection, but there's the phone number where I am in the Trinity system in Bloomfield, and I welcome any of your questions, and I appreciate your patience and your attention.
Fabulous. Okay, well, we're so glad you were able to rejoin, and we do have some questions. I've said it a few times, but again, if you do have a question or you think of something throughout this discussion, please feel free to drop it into the Q&A, and we will do our best to address it. We are at 8 o'clock at the hour. Are both of you okay staying on for an extra 10 to 15 minutes?
Absolutely.
Okay, perfect.
No problem.
Awesome. Thanks to both of you. Okay. So we're going to pick up where we left off. So this is a progesterone question. Can progesterone-only treatments be used in someone with a higher potential for clots?
Perfect. I can take that one on since I covered that. So it depends. I feel like all these questions I begin with, it depends. So it depends on what the reason for the higher risk of forming clots are. For instance, if somebody has a clot during pregnancy or when they're on a birth control, we presume that that was due to the hormones that they were on. And so in that case, we typically stray away from anything with hormones. Now, I mentioned the Mirena IUD, or the piece of plastic that goes in the uterus. Now, that has the lowest dose of hormones. That can sometimes be safe in people who have a history of blood clots. But there's other clotting disorders that we can have, or if somebody had a blood clot after a major surgery, or they broke their ankle and they weren't moving around much, that kind of changes what that risk is. So the short answer is yes, progesterone can be used in people with higher potential for clots. The long answer is probably should have a conversation with your physician.
Anna, can I add something?
Of
Absolutely.
course.
Yeah. Another angle to this problem is that when it comes to how medications are labeled, the FDA has what we call class labeling. And so birth control pills are known to be associated with an increased risk of clots. They contain generally both a progesterone and an estrogen. So progesterones are labeled that way all the time. Now, we think, based on the research, that it's more the estrogen that's the problem than the progesterone. Still, we have to be very careful in how we deploy these medicines, talk carefully. And this is depending on what we're talking about, this is a good situation for collaborative care with your hematologist to talk about what do you think the real problem might be, and is this a real risk for you? So like we just said, it depends. And there are a lot of plus minuses, but we generally think progestins are okay in the context of a clotting risk. But just like anything, your safety is paramount. So we should tread cautiously and with the help of other colleagues who are addressing this issue for you.
Perfect. And there's a follow-up to that. So if progesterone-only pills are prescribed for AUB, can they actually cause severe pain, bloating, and prolonged bleeding?
Absolutely. Yep, those are known potential side effects of any of those hormone pills or any of those hormone treatments, really. The bloating and the prolonged bleeding too. Sometimes with the progesterone, it's just such a low dose of hormone that it almost thins out that endometrium or that lining that we talked about. It thins it out so much that those blood vessels in the uterus don't have anything to kind of stop them from bleeding. And so we have weird spotting and weird bleeding for a prolonged amount of time. And so it may be that you just need either a higher dose of progesterone or need to have that estrogen added to make that uterus a little bit happier. But it absolutely can cause all of those symptoms.
Okay. Do fibroids decrease and or shrink after menopause?
The assumption is that fibroids are dependent on our internal hormones to maintain themselves. Therefore, with the lessening of the presence of those hormones in our system, we should lose support to the fibroids and they will tend to shrink. I think the data shows that this is generally true. It's important to emphasize that it doesn't, deflate quickly like a balloon, for example. It's a slow process that over time you will see fibroids decrease and maybe more importantly get less active in their impact on function for the uterus. Now, that's not 100% true. There are many patients I've encountered over the years that their fibroids more or less stayed the same. And then it becomes a matter of, were the fibroids an issue at all? And if they were an issue, was it a menstrual bleeding issue? And hence menopause generally intervened, if you will, to take that problem away? Or is it still kind of a bulk issue? And I have treated patients many times once they are in menopause, and that's defined by the fact that they're not having periods anymore. And blood testing also shows that there's not a lot of hormone production coming from the ovaries. And yet the fibroids can be a source of problems. So the general answer is the trajectory is for fibroids to become less of a problem, both in terms of their actual physical presence and size and their activity. But that's not 100% true. And you might remember in one of my slides, I said that this is a common and generally benign tumor. And so in the menopause, particularly as we're seeing a patient who's more going toward the age of 60 and beyond, a fibroid, particularly one that's enlarging, becomes a little more concerned for that rare cancer in a fibroid. Fibroids, we really feel, are very, very uncommonly going to be cancerous, but there is disagreement on what that number actually is. It's probably something between 1 per 1,000 to 1 every 2,000, but you'll find different numbers in the research. So you always have to individualize the care for every patient in terms of what the fibroids are doing or not doing when we're looking at somebody in menopause.
Okay. So we have another question. It sounds like this woman has been through many years and many different procedures. So it's 20 years since a laparoscopy and she was diagnosed with endometriosis. So she's seen a lot of different practitioners expressing concerns about her pain without resolve. And she has excessive bleeding, trial and error with birth control, and is looking for advice on either another laparoscopy or what would you recommend for the next best steps? It sounds like she's having trouble feeling like her concerns are being addressed by her provider.
Well, I mean, it sounds like that middle paragraph, I just went to a doctor that listens, is probably one of the best things that this patient has going for her at the moment. Because what this patient is presenting is one of the hardest things for us as gynecologists to manage. The issue is the chronicity. Doctors, us allopathic doctors, in our training, we're very good at treating acute problems. Somebody has abdominal pain, it's a hot appendix, we take out the appendix, the patient's better. Chronic problems in medicine, we have a lot more problems with because of the complexity of the central nervous system in its role in maintaining pain in patients. And so chronic back pain, chronic headaches, and chronic pelvic pain functional intestinal problems like IBS and things like that. All are very challenging because of the limits we have in understanding all the mechanisms that sustain the pain experience for patients. And the role of endometriosis is in sustaining that pain also is not 100% fully understood. Somebody like this patient often will, especially if it's going on a couple decades, you'll often see patients having repetitive surgeries, laparoscopies. The patient will feel better for a time, but then pain tends to recur. And overall, when you look at the research on laparoscopy and endometriosis, pain recurrence is at least 50%. And so there's a saying I give patients when we decide on surgery where I say to them, when it comes to endometriosis, the arc of surgical care to get you safely through a surgery and recovery is never the end of overall management because it's a chronic ongoing problem. And so once you're at this stage, the role of laparoscopy for me is primarily if I am convinced on the basis of the history, the physical, and the exam and imaging that there is residual or persistent endometriosis that is causing some or all of the pain, and therefore it is worthwhile to go to the operating room with all its risks to better excise that tissue. But those set of particulars has to be present if I feel surgery is appropriate in that case. And that fits into all those other things I talked to before. What are our goals? Is having a pregnancy a present goal? Have we abandoned, or that's not important to us, having a pregnancy, and other such things? So it's a challenging problem, chronic pelvic pain and endometriosis. Has to be individualized care. And there are a full spectrum of non-surgical options that are worth talking about. And surgery, to me, is reserved for the clear evidence that residual endometriosis is causing the pain. And at 20 years out, that probably is the minority of patients. So I know that's a kind of a hedging answer, but unfortunately, the answer really has to take into account a full spectrum of complexity when it comes to chronic pain.
Okay, I think that was a good kind of like a 10,000-foot view, right? Without knowing the person personally. I will say that both of you are accepting new patients. So if you are interested in kind of doing a deeper dive into your personal health, you can certainly make an appointment, and we will share that contact information in our follow-up email. So we have a few more questions if you're okay sticking with it. So can you talk a little bit about how you diagnose fibroids?
I'm staying silent because I've been talking too much already.
You're fine. I answered a bunch of questions earlier too.
Oh, okay. Well, you go ahead. Go ahead.
So, the first part is the exam. Sometimes if they're larger fibroids, we can feel them on the exam. Even if I suspect and feel them on exam, I will still get an ultrasound just to take a look at those. Ultrasound is probably the best way that we have to look at those. And again, the transvaginal ultrasound that I discussed earlier. Sometimes if we're just not sure, if we see a mass that could be a fibroid, could be a cyst, it could be, a cancer, sometimes we'll get an MRI to look at that a little bit further. But typically we can diagnose those fibroids from an exam and then an ultrasound.
And to piggyback on that, one of the great values, ultrasound is very accessible, relatively inexpensive, and it is the gold standard for us to image the uterus and the ovaries. The value of an MRI, I have found, is that when you look at the other interventions we talked about for fibroids, MRIs can be really good adjunctive tests to determine whether you got a good patient selection for some of the options I talked about. And the other thing about MRIs is that looking at them, ultrasounds, the pictures, if you are not a radiologist, doctor, just, average person, they don't look like much. But an MRI is something that's sitting with the patient. It's very helpful to navigate where your fibroids are, what they look like, how many there are. which can be very, very enlightening to a patient to sit and say, here's this one, here's this one, here's this one. And a picture can be worth 1,000 words. So I found it to be a type of a test that in a lot of situations helps patients navigate their fibroid issue and decide on which type of treatments appeals to them.
That's a great point. I think I agree. If looking at a ultrasound image, I have no idea what I'm looking at, but it is nice when you can actually understand and really make sense of it. So that's good advice. As you approach menopause, is it normal to have longer duration periods? And I'm guessing that means longer periods, not longer time between them. I'm not sure. Maybe you could address both of those. So longer periods while you're having your period, and then is it normal to go longer between periods?
I can take this one. So that transition between going from those normal monthly periods until we stop those periods, menopause is 12 months with no period. So it's kind of a retrospective diagnosis that you get. But that time period between going from regular, monthly, or I should say just regular periods to that menopause state is really weird for the body. The hormones are up, they're down, they're sideways, they're all over the place. And the body's just trying to figure out what is going on as that overall estrogen level in the body decreases. And so those periods can do a whole host of things. Sometimes they space out, sometimes they get heavier, sometimes the duration between them gets shorter. Like this person mentioned, sometimes they become the actual period itself, the duration becomes a little bit longer too. Unfortunately, there's no one thing that I say, oh yeah, as you go through this transition, your periods are going to do X, Y, Z. It's so variable from one woman to the next.
It really sounds like we're all sort of unique snowflakes, right? It could, everything could be the same for some and very different for others, right?
That's exactly right. That's exactly right.
And what age does that start? Is it possible when you hit 40, you could be in those stages of early menopause?
Correct. So when we start to lose that estrogen function at age 40 or below, it's considered premature ovarian failure. But if it happens after age 40, that can be the transition. The average age for menopause, when those periods actually stop, is about 51 and a half years old right now.
Okay. And how long can that sort of premenopausal period last?
Oh boy. So, I tell patients this is not the answer you want to hear, but it could be anywhere from 1 year to up to 10 years you can have those symptoms. Most people don't make it all the way to 10 years, but it absolutely can happen.
Okay, so you can see it start happening at 40 and kind of carry you right through the decade if you're one of the lucky ones. Okay. When considering fibroid removal, how big would the fibroid need to be to move forward with a procedure?
I'm sorry to use the phrase again, but it depends, There has been a general philosophy in gynecology that I grew up with over the years, that if it's not bothering you, don't bother it. So in other words, a fibroid that's asymptomatic, even if it's on the larger side, why treat it? Why do anything? There might be, considering the new technologies we have, particularly the ablations, and I've had conversations with some of the other people who've been involved in the research and in the innovation. There might be an idea that as you ascertain that somebody has fibroids, why not nip them in the bud and treat them when they're small and easier and more successful to treat, because as they get bigger, some of these more limited treatments get less successful. That is an idea that has yet to be studied research-wise, and before I think doctors should start treating things this way, that should be studied in a systematic fashion. But generally, if somebody has fibroids and they're prominent enough that a patient is aware of them in some way, I think it's reasonable if the patient wants to deal with them to go ahead and treat them, even if, for example, the periods aren't a problem particularly, or even with they're not having any spectrum of pain issues. And what has to be taken into account are what the patient goals are and keeping safety for things like future fertility, because doing any treatments on the uterus can theoretically have some negative consequences on the ability to get pregnant. That's in addition to the fact that knowing when fibroids are in the way or not in the way of getting pregnant is a very difficult matter to discern, because lots of women get pregnant with their fibroids, and the fibroids didn't prevent them from getting pregnant. And so there's a whole range of issues that you have to talk about. But I think in principle, fibroids are an abnormal tissue, regardless of the fact they're common. They are an abnormal tissue. And if in any way they are disturbing to the patient, even if it's merely because they're there and their point of view is, look, I don't want them in my uterus, we're going to do something about it, that they are pathology. And if the patient understands the indications, the risks, and what benefits you're going for, and they want to do an intervention on that fibroid, then I think that's okay to do so. And a myomectomy, laparoscopic myomectomy, or a fibroid ablation, all done in consideration of what the patient's short and long-term goals are, fertility and otherwise.
Okay, and if a patient has like asymptomatic fibroids, that's something that you would find during an exam and maybe bring that up to them. Hey, I think you might have fibroids there, and then you would explore that with further testing. Is that kind of how that would come about?
Yeah, I think in this day and age, I think it's incumbent upon us physicians to make the diagnosis. Yes, get some imaging done, and then allow the patient to follow that over time longitudinally so that she can see what's going on. And if we see progressive growth, and we will see this pretty commonly, the patient has known fibroids, but over time now we're seeing some increase in size, and that may be compelling enough to the patient, perhaps even with some developing symptoms, that they would like to do an intervention at that point. But it's helpful if you know about it early when they're smaller, and that you can watch them carefully over time, let's say year by year.
Okay, so that's a good testament to see your OB-GYN annually to make sure that you're keeping an eye on those types of things and finding them when they come about. Okay, just a couple more questions. When considering fibroid, okay, we answered that one, I'm sorry. So what are the lifestyle considerations when choosing hysterectomy? One slide mentioned patients weren't told what happens after and didn't feel fully informed. Can you expound upon some of those considerations?
I think that we doctors can do a much better job than we do to understand what our patients' concerns are and make sure we fully discuss all of the issues of the interventions we do. When it comes to hysterectomy, for example, a common issue for patients when they're contemplating whether a hysterectomy is for them or not is the question, for example, of menopause. And it's a common assumption that people have that taking out my uterus means menopause. And for almost everything we do, that's not true. There's no reason that the ovaries have to be removed. So that's an issue that has to be clarified for patients, and they'll find that a very helpful distinction. For example, I had a patient tell me, you know, the reason I resisted a hysterectomy was because I read that hysterectomy increased the risk of heart disease. Now, that's a complicated question, but for the most part, what she was understanding was that surgically making her menopausal, and which is a sudden thing, one day you're with your ovaries, the next day the ovaries are gone and you're menopausal, is associated with increased risk of cardiovascular disease. However, just taking the uterus without the ovaries, depending on the age, not necessarily so. So that's important to make a distinction about that. The other issues after hysterectomy, besides talking about the immediate risks of the surgery itself and the postoperative risks of things like infection or postoperative bleeding and other things that are the reasons people will need to go back to the hospital after a hysterectomy are the longer term issues in terms of vaginal healing, vaginal support. And I had mentioned in my talk the concept of prolapse. So post-hysterectomy, prolapse, and issues of discomfort. The data would suggest that patients, for example, with pelvic pain, most are improved after hysterectomy. Maybe 10% of patients are not. And about 5 to 10% of patients have new types of pain after hysterectomy, things like pain with intercourse due to the fact that perhaps the upper vagina has a different shape and contour, and now the act of intercourse is creating pain. So those are the things that we need to discuss with patients and make them aware of so that they're ready to ride out this whole course of treatment with us with reasonable expectations, and then knowing how we're going to manage these things should they arise.
Okay, and I think that's some great fodder for our patients to have some questions to ask. How will this impact my life moving forward, and really addressing some of those questions. So I think that's very important that you're pointing that out from a physician's point of view. One more question here. So this should be the last one, I believe. Can you discuss the risk of hysterectomy if you need the surgery with the larger incision, which will include removal of the cervix? Did that make sense? Do you want me to read that one more time, or did you get that, Dr. Eisenstein?
Yeah. The reason that we like the idea of the small incision surgery, whether it's a laparoscopic or robotic laparoscopic, is the fact that the data shows us that the spectrum of risks of hysterectomy, which include blood clots in the legs, infection in the vagina or in the bladder, injury to areas of the internal organs such as the bladder, the urinary system, or the intestinal system. Those things are less with laparoscopic surgery than with open surgery. And that has to do with some of the dynamics of what happens when you have a larger incision versus the keyhole incision. Now, having said that, all of those things have to take into account patient selection and who is a good candidate for each type of surgical approach. And so if you have either the type of anatomy or a medical background, medical condition in your background, that doing things through the keyhole incisions, again, whether laparoscopically or with the robot, do not give you all that advantage and may be a disadvantage, and there are certain situations like that, there is still a role for that traditional larger incision if it means it's best for treatment of the problem and the long-term success of the operation and your safety. And so that's why in my last slide, I mean, I went at it from the point of view of what patients say they prefer, which was to communicate a requirement on our part as physicians to take into account what patients perceive and what they prefer. But it means that we have to have a conversation in which we're not tied to one approach, but tied to an approach that is the most appropriate for each individual patient, and have that talked through with them. A hysterectomy is an elective operation. There may be a real need for it and a need that the patient feels they want to get it done soon. But overall, it's an elective procedure, meaning it's a choice amongst many to deal with the problem. Therefore, let us take our time to talk about it together as patient and physician, and to understand the journey that it's going to entail from scheduling to the operating room to going home to recovery. And that we have to have that conversation once a decision is made that taking my uterus out is what I want to do as a patient.
Does having a prior C-section during the birth process, does that change your risk? Is that a little bit easier to do that procedure, or does that sort of across the board, it varies for everyone?
Cesarean section is not a reason you must avoid various approaches to hysterectomy. What the cesarean section tends to do, since you have to move the bladder away from the lower part of the uterus where we make an incision to deliver the baby, the bladder tends to come and scar back to that area. And so the bladder is probably a bit more at risk to being injured during a hysterectomy. That's true whether you do it through a traditional laparotomy incision or you do it laparoscopically or robotically. Either way, the surgeon has to be aware of it, has to pay attention to their dissection to get the bladder out of the way. And in my opinion, and this is my practice, should look inside the bladder at the end of every case to make sure the bladder is intact and undisturbed. Because the key thing is, if unfortunately you make an incision into the bladder while you're trying to get it out of the way, that's something you're trying to avoid. It's not, it's not a desirable thing to happen, but it's part of the potential complications. And your job as the surgeon is to pay attention, ascertain that that's happened, and then repair it, because repairing the bladder is not a very complicated thing to do. You just simply have to suture it watertight and then let the bladder heal for 7 to 10 days on rest when the patient's at home. So the prior cesarean, or sometimes we deal with multiple cesarean sections, does create some challenges in the dissection. But how I handle it is to explain that to the patient, explain what we do to protect the bladder, but also to make sure that in doing the procedure, to determine if we do have an injury to the bladder as part of our procedure, and by making that diagnosis during the surgery, it makes the repair much simpler than if it's one of these situations, which also occurs sometimes, where the patient's gone home and then we find the bladder has a leak in it, and there has to be sometimes more surgery after that, and it's not as simple to go back to the OR. So it's not a contraindication, meaning it's not a reason we can't go forward with hysterectomy, but it's something that we have to manage appropriately and counsel the patient about.
Okay, so this one is, what are foods that decrease inflammation?
That's a great question. So when I see patients and discuss this in the office, I have a nice little handout that I hand them that has some of the foods that you should increase in your diet and things that you should decrease in your diet. So in general, just off the top of my head, spices like turmeric, cinnamon, cumin, making sure that you're getting those healthy fats. So like the omega-3, so that's like fatty fish, the avocados, and with your fruits and vegetables, so antioxidants will decrease inflammation throughout the body. So antioxidants are usually in foods that have really like dark colors. So think blueberries, blackberries, plums, spinach, broccoli, carrots. So things with that really deep color can increase your antioxidants and then decrease your inflammation. With that said, too, on the flip side, too, so some of those foods that can increase your inflammation are all the good stuff. So it's the dessert, the sugars, the carbs, all of our processed bread, too, like our white bread, all the stuff that tastes really, really good. And then meats, too. So like red meats, anything that's processed, like hot dogs, what else? Like sausage, pepperoni, that stuff. All of that can increase your inflammation too. So you can eat all these foods that decrease your inflammation, but just know that if you're eating some of those bad foods too, they may not completely balance out. It's really important to decrease the amount of foods in your diet that can increase your inflammation too.
Here's another question. This is around hysterectomy, which I know Dr. Eisenstein was talking to, but I thought maybe you could kind of give your opinion on it, and we can always get him to weigh in if he is able to rejoin. So I've asked for hysterectomy several times due to fibroids and heavy periods. However, I've been turned down and asked to do other treatments like birth control instead. Why is this the case? What are they not telling me?
So that's interesting. A hysterectomy is a major surgery. It does have lots of risks with it. And so when I see a patient who comes in and says, I want a hysterectomy, I think Dr. Eisenstein was just starting to touch on this on his presentation too, but I go through those risks too and those benefits and say, you know what, maybe a hysterectomy is not the best thing for you right now. Sometimes you have to do, I call it a Band-Aid. In the meantime, you have to do a short course of something else as you're waiting to get that workup done or figure out what is the right type of hysterectomy or what is the right procedure for me, because a hysterectomy is just taking out the uterus and the cervix, but sometimes we want to take out the fallopian tubes and maybe there's a cyst that we need to address. And so maybe I would assume, without actually seeing the office, it's hard to say, but my guess is that's maybe what's happening is they're trying to get the workup started and putting a Band-Aid on it in the meantime, until you can actually get to that hysterectomy. But that's a great question. Absolutely. If you feel like, at the end of your visit, you feel like, I just feel like I wasn't heard, feel free to just reiterate that and say, hey, I'm really interested in this hysterectomy. Why don't you think that's a good idea for me? Or why is that not what we're offering today? Just ask those questions. Because a lot of times, we've got so much going on in our head and we're thinking of all these different things. And sometimes I don't verbalize that stuff too. So feel free to ask.
That's a great piece of advice. And I know in a lot of different specialties, a second opinion is pretty common. Is that something that OB-GYNs welcome as well?
Oh, absolutely.
Okay.
Absolutely.
And could you even, I know there's oftentimes several practicing OB-GYNs in one location. Could you see someone else in the location, or would you recommend going to another location for a second opinion?
Whatever the patient feels most comfortable with is what I recommend. So they absolutely can see somebody else in that same practice. Just because you're seeing somebody in that practice doesn't mean that you're going to see that other doctor in the hallway either. I think that's what I hear a lot. Is like, oh, I was so afraid to go back because I thought that doctor was going to recognize me in the hallway. Probably not. Or even if I do recognize somebody I've seen before, I'll just say, hey, I don't know what they're there for. They might be there for labs. They might just be dropping off a urine. Who knows? I don't know. And so don't feel bad about getting that second opinion if you feel like that's what you need.
Right. These are big decisions. So ultimately you need to do what's best for you. And I would imagine your OB-GYN would want what's best for you as well.
Exactly.
Hey, can drinking coffee make your period cramps worse?
Oh, that's a good question. So caffeine, it's a wonderful thing. But it does irritate the GI system. That's one reason people have to use the bathroom typically shortly after drinking a cup of coffee. However, keep in mind, it usually doesn't interact with the uterus directly. However, if you increase that cramping that's going on the bowels that are right next to your uterus, you can cause irritation and inflammation in the uterus too. And so it can seem like that's causing your cramps when really it's your bowels just being irritated around your uterus that's making that even worse.
That's so interesting. Yeah, I bet it does feel kind of similar to have that bowel pain versus uterine pain. That's a great thought. But you can always get decaf. I know that's taboo. All right.
Who
So
drinks that?
are there any non-invasive diagnostic tests to confirm endometriosis?
That's a great question. Endometriosis is one of those tricky diseases, and it can be very mean and nasty too. So yes and no. Sometimes we can get clues of endometriosis on an ultrasound. Sometimes we can get clues of endometriosis on an MRI. But just because we get a ultrasound or an MRI that says no signs of endometriosis doesn't necessarily mean that it's not there. And so I think what that question is probably alluding to is that the most definitive way to get that diagnosis is with surgery or typically laparoscopy, where we do little incisions and put a camera in the belly and look around to get that diagnosis. But we usually do start with an ultrasound first and an MRI to see if we can find those clues to get that diagnosis without having to go through that procedure and all of those risks.
Another inflammation question. How about alcohol?
What about it?
Can it cause inflammation? Sorry.
Oh, absolutely.
Yeah.
It releases lots of free radicals, which can cause lots of inflammation.
This person says they're going to remove my uterus. It's very large and bleeding so bad after they remove fibroids. What do I expect after the removal of my uterus? What is that
So
recovery?
it sounds like this person's having a hysterectomy
Yep.
or just fibroids coming out, a hysterectomy.
Yes, hysterectomy after fibroids were removed in the past.
Gotcha. So if you've had fibroids removed in the past, we do know that that increases the chance of having adhesions or scar tissue in the belly. And so that can make the hysterectomy a little bit more challenging. Earlier, I mentioned as we talk about hysterectomies with patients, there's several different ways to do it. And so we go through some of these risk factors or some of these qualities that they have to determine which is the best method. So what you can expect after kind of depends on the way that that hysterectomy is done. So if we do a major, it's called abdominal hysterectomy, where we do an incision much like a C-section and do essentially everything open. We take everything out that large incision. The recovery is a little bit more because there's a lot more healing that has to be done. There's a higher risk for scar tissue and for hernias too after that. And so that recovery is a little bit more rough. Now, if we're going to do it robotically, now that has tiny little incisions, and the way that procedure is developed, the robot does not put a lot of tension on those incisions. And so the recovery is much better afterwards, so much so that some patients go home the same day as their hysterectomy with a robotic. Now, like I said, if you have fibroids, I would probably expect that you have some scar tissue from that previous procedure. And so it may be a little bit more complicated of a robotic surgery. You may not go home that night. But like I said, it kind of depends on what type of hysterectomy you end up having.
Okay. And once you have a hysterectomy, are there any other things that have to happen? So you're removing your uterus. Do you have to take medication to supplement anything, or can you just sort of go about your life period free?
So that's a great question. So when we say hysterectomy, we're talking about taking out just the uterus and the cervix, typically. And so when we're talking about that procedure, we also then discuss, do we want to take out, hi, Dr. Eisenstein, we're just doing some of the Q&A stuff.
Yeah.
And so we also talk about, do we want to remove those fallopian tubes? Because if we take the uterus, they're not really doing anything for us other than potentially going to cause cancer later on in life. Now, the ovaries is a different situation. It's always good to go through that natural menopause if you can, if you're able and healthy enough to do that. And so we don't always take those ovaries. If we leave the ovaries in and you go through that natural menopause, there's no hormones or any supplements that you need to have after that hysterectomy. It's just getting the uterus out, those periods stop. You go through that healing process and then go about your life.